Thank you. It's also so beautiful to do this in the ISQua African Network, where I have been a part of ISQua, I think, for a couple of years now. So today we will be discussing improving the availability of NCDs, so non-communicable diseases, diabetes in particular, data for decision-making in Nigeria. Okay, so to guide our conversation today, some of the things that we will go home with. So some of the takeaways will include: one, we'll be able to identify and mitigate potential challenges that may be encountered in designing effective data improvement programs. And then also, would also be able to understand how to develop effective alternative data collation systems in times of crisis. And crisis here, I'm speaking really specifically to the pandemic, which happened globally this year. Okay, so an outline also just to give some structure to our presentation today and to help us with, following through. We'll be looking at the disease burden, so understanding the disease burden globally in Africa, in Nigeria, and then what the DAC project, the Diabetes Awareness and Care Project in Nigeria, is doing to intervene and to close some critical gaps. And then we'll also look at reimagining data systems in the wake of the pandemic challenges and then lessons learned. Okay, so globally, I'm sure we all know of the SDGs, Sustainable Development Goals. The inclusion of NCDs in the SDGs is really proof that NCDs have become a priority globally and a huge challenge. In fact, a few years ago, for the very first time, WHO had referred to NCDs as a pandemic. So we're at that point where something needs to be done critically. SDG 3 talks about good health and well-being. And then SDG 3.4, talks about NCDs in particular, and how by 2030, the aim is to reduce by 1/3 premature mortality from non-communicable diseases through preventing and treating, and then promoting mental health and well-being. So that's a mouthful, but it's really a lot around SDG 3.4 and the focus on NCDs at this time, which is critical. And so it's also important to note that the global burden of disease, of diabetes, has almost doubled between 1980 and 2016. That's huge. And LMICs, so low and middle income countries and poorer nations, are bearing the brunt of this problem. Globally, NCDs, because NCDs is a global problem, we have over 400 million adults who live with diabetes today. And this is expected to rise to about 700 million. That's huge by 2030. And then it's also important to note that almost 80% of adults who live with diabetes who have diabetes live in low and middle income countries. Now that's also a problem because some of these nations are least equipped with the capacity to manage this disease. So there is a problem. In Africa, we have over 19 million people who live with diabetes. And again, the number is expected to increase to about 47 million people by 2045. And of all the people who live with diabetes, Africa has the highest proportion, of undiagnosed people. So 3 in every 5 who do not know that they have diabetes. And this is also critical for diabetes management, for building systems to improve NCDs in countries. When you are faced with such high degrees of ignorance, there is definitely a problem. We have a problem on our hands. What's the picture like in Nigeria? In Nigeria, we have about 2.7 million people who live with diabetes in the country, Nigeria actually ranks second. So we have the second highest number of adults who live with diabetes in Africa. We're only second to South Africa. In fact, the 4 highest countries are South Africa, Ethiopia, the DRC, and then Nigeria. And this is a huge problem because globally we're among the top 10 countries, with people living with impaired glucose tolerance. And I think what is important to note here is the fact that many people fear that this is an underestimation because there are still concerns with data management, data collation systems. And so the numbers that we quote, people still fear that these just might be, underestimations of what the truth, actually is. Now, it's important to also note that the WHO recommends that countries carry out step surveys. Step surveys are stepwise, so stepwise approach to surveillance. I put that in the footnotes, and wherever you see the acronyms, I'll try to spell them out, but they're also in the footnotes. So a stepwise survey to surveillance for NCDs. WHO recommends that countries carry these surveys out, every 3 to 5 years. However, for a country like Nigeria, with the burden of disease that we have for NCDs and diabetes in particular, the last national step survey was conducted over 2 decades ago. So that's sometime in 1991, 1992. So it's almost like we're saying it was conducted in the last millennium. So the thing is, this is critical because countries, in fact, smaller countries, so countries like, by smaller I mean in population, right, in size, countries like Kenya, Uganda, Rwanda have more up-to-date surveys, And so for a country like Nigeria, and when we're required to make evidence-based decision-making, but we have, data as old as over 2 decades ago, you can then imagine the concerns, that we have. Yes, there's a more recent subnational survey, which was conducted in Lagos. Lagos is the most populous state in Nigeria, but this is also over a decade old. And so for a country as diverse as Nigeria and with a population of about 200 million people, it's difficult to utilize Lagos, which has about 20 to 21 million people, as an effective proxy, for the country. So nationally, we still have a dearth of data, and this is a concern. So despite this burden of disease that we have been able to conceptualize, there exists, a paucity of data, like I have said, and NCD indicators are not adequately captured in our mainstream health information systems. Now that's critical because when you are not mainstreaming NCDs, even in data collection, data demand, availability, and in fact the entire value chain of data, so from collection, synthesis, and use for decision making. When NCDs or when problems or huge disease burdens like this are not mainstreamed in routine data collection systems, then there's a problem because then we run the risk of exclusion. Okay, we definitely do not have them included, so there definitely is a problem. So there's a focus on so many other things, which I'm not saying are not, which obviously are important, but we must understand that we must simultaneously address many of these issues because we have so many of them on the front burner at the same time. Now, in Nigeria, we have what we call the district health information systems. And this health information systems it's a virtual one, and it is the only national database where every single health facility in the country is expected to upload data into. So that's our national dashboard. And I have included a picture on the left. I'm sure you can see it. It's important to note at this point that when you see under the NCD module, you can see that we have only one indicator. We can see it in red, only one indicator for measuring or for tracking diabetes mellitus. And that indicator is diabetes mellitus new cases suspected. So that's the only thing that exists, or the only indicator that exists on our district health information systems, which is the national health database for facilities, so healthcare facilities in the country. So if this is the case, then you see that we have a huge challenge on our hands and we have a lot of work to do. Hence this presentation, okay? Most of the data that we utilize in Nigeria now are either from pockets of studies that have been conducted in different parts of the country, or from proxies as well, or from sources like the International Diabetes Federation, WHO, and a couple of others. But in this presentation, we'll be able to see where we are and what we're doing, thus far. So considering that this is the problem we have on our hands, what are we doing concerning this? In 2017, the NCD Unit, so the Non-Communicable Diseases Unit of the Federal Ministry of Health, collaborated with HSDF to submit a grant proposal for a WDF-funded DAC project in Nigeria. So the WDF is the World Diabetes Foundation, and DAC is the Diabetes Awareness and Care Project. So we came together to submit, to design a proposal and to submit one. This was in 2017, and it was designed to target one focus area, which is diabetes. Okay, we did this, and it was good to know that it was successful and the grant was approved. We developed a work plan and we started engagement for program implementation. Some of the things that we did, we had conducted desk reviews, literature reviews, which uncovered 3 critical gaps in diabetes management in Nigeria. One of them was high levels of ignorance. So studies had shown, so many studies conducted had shown that among diabetes clinic attendees and healthcare workers, there were considerable levels of ignorance, even with people who had diabetes and had been living with this, for years. There were also studies that showed that many diabetes clinics lacked basic knowledge and basic equipment for diabetes, for screening for diabetes and hypertension. So that takes me to diabetes management, which was the second critical gap that we had observed as well. The primary healthcare center in Nigeria is the entry point to healthcare delivery. But then aside the concerns of high levels of ignorance, there were issues with infrastructural capacity. So things as basic as glucometers and other equipment. And then the last critical gap was around data, which is the crux of our discussion today. Yes, there existed operational plans for diabetes and all of that. However, like I had mentioned, we didn't have sufficient indicators to track diabetes on our mainstream national health database, which was a problem. So we were faced with 3 huge challenges: high levels of ignorance, weak diabetes management, and then poor data reporting. And of course, that when there's poor data reporting, then there's a paucity of evidence to make decisions, so this kind of hinders evidence-based decision-making, which is at the crux of policy-making, for every country and for governance in general. So what was our theory of change? We proposed that if we targeted interventions at improving those 3 big challenges, we would have, good outcomes. And some of our interventions included, awareness. We wanted to increase awareness, increase access to care. We were going to train healthcare workers, work with the states and the federal ministry as well to provide equipment to facilities that were lacking them, and then improve data reporting systems. And based on this, we aimed that at the end of 2 years, we would have improved knowledge on diabetes, at least in the pilot states, which I will show us the 2 states where we intend to work, and improve the quality of care provided at primary health care centers, which is the entry point for healthcare in our country, and then increase the availability and demand and quality, of diabetes data for decision making. So we agreed on a set of criteria to select our pilot states. We decided we're going to work in Imo and the FCT And like I had mentioned, due to insufficient data sources, we had studies, yes, but we didn't have national, globalized data from where we could make proper inferences. So we utilized proxies to measure diabetes burden by state. Some of these included total overweight or obese women. I'm sure people will say, oh, why women? So that's what we have, for example, in the National Demographic Health Survey, which is another survey that measures, other disease entities. There we have an indicator that states total overweight or obese women. So we use things like that for proxies to measure. We also utilized data on education. We prioritize states with high literacy rates because of the number of information, education, communication materials that we were going to be sending out. And then we looked at the feasibility of implementation, security challenges, the presence of good stakeholder management, HSDF program in some of the states and all that. And then we finally settled on Imo in the southeast of Nigeria and the FCT, which is the capital of Nigeria in the north central. So in 2018, after the grant approval, like I had mentioned to us that the DAC project was going to improve awareness, access to care, and the availability of diabetes data for decision-making. Okay, these were the three big objectives, under this goal. But as you know, like I had mentioned today, I will be talking a lot around data and what we're doing, and I won't be discussing for want of time, of course, and for the purpose of this presentation, Objective 1 and Objective 2, which is to improve awareness and access. The Honorable Minister for Health, so the immediate past Honorable Minister for Health had inaugurated the DAC Steering Committee, the Diabetes Awareness and Care Project Steering Committee. This committee was to drive the implementation of the DAC project in Nigeria. So there, smack in the middle, is the former Honorable Minister for Health, as of 2018, and then flanked by his directors and other policymakers and stakeholders in the country. Like I said, we're working in 2 states. So the Diabetes Awareness and Care Project, which was our intervention, our brainchild, was to work in 2 states, in the FCT and Imo. And the number of facilities that were expected to submit data monthly, normally, on the DHIS2, was 110. Now, let me just take us a few steps back. Like I had mentioned, every health facility in the country is expected to submit data to the district health information systems every month. And that's our national health facility database. But like I had also mentioned to us that we have only one indicator measuring or tracking diabetes there. So on our project, we're working in 110 primary healthcare facilities in Imo and in the FCT, 56 in Imo and 54 in the FCT across different local government areas. So the number of facilities that were expected to submit at least one data report from the project, from the Diabetes Awareness and Care Project, were 110 from Imo and from the FCT. So to improve, the availability of data on the DAC project, on the Diabetes Awareness and Care Project, we utilized a 2-pronged approach. So we were going to work high level with policymakers, and then we're also going to work with frontline healthcare workers who were the soldiers on ground. With policymakers, we're working with policymakers at the national level. So that's at the federal in Nigeria. Nigeria runs a 3-tier system of government: federal, state, and local government. So at the federal, we're going to work with policymakers. At national, so national here, I mean the federal, and subnational, the states. For national, some of the things we were going to do included expanding the national diabetes indicator, so improving the number of indicators, for tracking diabetes in the country, okay? And then at the subnational level, we were going to have policy meetings to discuss outcomes from the project, to have iterative conversations, and then utilize all of this data to improve decision making. With the frontline healthcare workers, we're going a bit more granular, doing stuff around data training, mentoring sessions for data state data review meetings, among others. Remember that all of this were tailored at improving data, through the entire data value chain. So from, collection to analysis and synthesis and utilization for decision making. So we're working through that entire chain. For policymakers, we engage policymakers, like I had mentioned, at the federal and state levels to improve data visibility and demand. One of the things we're doing at the national level, is to work. So we're working closely with the Federal Ministry of Health on this project. It's a collaboration between the Federal Ministry of Health and HSDF. And one of the things we're doing is to expand the national diabetes indicator, so improve or increase the number of indicators that track diabetes data in the country. And one of the ways we have started to do this, was to adapt the World Health Organization package of essential non-communicable disease intervention, so the WHO PEN. Okay, Nigeria won't be the only country utilizing this. We sat down with so many stakeholders and experts to adapt these WHO PEN tools, especially, and the DAC project was coming, at the right time. So we decided we would utilize the DAC project to pilot, this package of essential non-communicable tools, especially for diabetes and by extension for hypertension. And so the idea was to pilot these tools in these two states in Nigeria, and then garner all of the feedback, the challenges, the benefits of the tool, and all of that, and pass this across to the Federal Ministry of Health, and utilize this in the conversations going forward that would lead to the expansion of the national diabetes indicators in the country. The second thing we're doing with the national is really engaging with the Office of the Director of the Department of Planning, Research, and Statistics, because this is the office where this data is domiciled and managed. And for every time there is a reiteration or a revision of the DHIS2, so the District Health Information Systems, like I had earlier explained, all of this stems from this office. So we had, all kinds of advocacy visits. He had been invited to steering committee meetings on the DAC project. And we're working really closely with that office to ensure that by the next revision of the District Health Information Systems, we'll have an inclusion of diabetes indicators there. So this is, being awaited. And then at the state level, subnationally, like I had mentioned, we hold policy meetings quarterly, and these are really aimed at providing a platform for stakeholders to review the data, to engage the data, make informed decisions, tweak policy if need be, and for better outcomes. So this is this is a picture showing one of our roundtable policy, high-level policy meetings where we sit down with stakeholders, to really discuss and to harness, utilize all the feedback from the data to make for better decision making in the country. Okay. Now for the frontline healthcare workers, remember I told you that it's a two-pronged approach. We're working, with the policymakers and with the frontline healthcare workers. For the frontline healthcare workers, in that data systems, value chain, what are we doing with them? One of the things that we're doing is training. We trained healthcare workers. So we had one of the didactic trainings where we trained them on the use of those WHO PEN tools, how to make use of them, because these tools, we had quite a couple of them: client intake booklets, treatment registers, screening registers, referral booklets, among others. So how to make use of these booklets. So we had a one-off training, and then we had a periodic mentoring sessions. Okay, so experts, who had been drawn from the Federal Ministry of Health, the state ministries of health and their agencies, experts, from endocrinologists to endocrinologists as well, would visit facilities quarterly to ensure that things were going as planned, that these data tools were being utilized properly, gathering all the feedback from utilizing these data tools, understanding the challenges that healthcare workers face, and just collating all of this through a structured mentoring visit, which holds every quarter in both states. Also, we have what we call state data review meetings, where healthcare workers from all of these implementing facilities gather together to analyze their data, review the data, interrogate the data, engage with the data. You know, and at these meetings, we also have stakeholders present, share performance, successes, challenges. All of these are aimed at achieving the same purpose, which is improving data management processes in the country, mainstreaming diabetes data, you know, gathering this feedback and utilizing it for decision making. These are some of the data training and on-site mentoring sessions, some of them that had held didactic, you know, so one-off sessions, and then some of them that held at facilities. You can see the picture in the middle. That's at a particular primary healthcare center in a state, okay? So with the advent of the COVID-19 pandemic, what then happened? Or what has changed? Because many of these data processes in the country are manual. Many of them are not yet digitalized. So we still have, you know, data forms that would move from one stakeholder to another and to another before they are finally entered into a database. Okay. So in the wake of the pandemic, you know, then there were concerns, because we had lockdowns and we had all of that. So we'll just look at that in this next session. So prior to the pandemic, the data collection process followed a seamless manual flowchart, you know, involving different stakeholders. You know, in step one, these data tools are filled at the facilities. Remember, I had said that healthcare workers had been trained on how to utilize these tools. And so they were filled at these primary healthcare centers. After they were filled, these tools come in triplicates. One copy of the tool is kept at the facility, and then one copy is submitted to the, or two copies are submitted to the state monitoring and evaluation officer at the local government level. These M&E officers collate these two identical signed and completed data tools from the facilities. Now, remember, because these WHO pen tools that are currently being utilized are not on the district health information systems. They are not there currently. I have showed us a picture. We have one diabetes indicator on the district health information systems now in my country. So these are not yet there. So they are entered into a parallel database, another database where they are housed pending the expansion of these indicators on the DHIS, so the district health information systems. So when the state M&E officer collates two identical copies of these data tools, HSDF will manually collect a copy of this data tool. And after cleaning and validation processes have been conducted, this data tool is then entered into an Excel database for storage, for analysis as well. And then this is from this database that we analyze, understand trends and patterns, outliers, provide feedback to health policy makers. When we sit down at policy making, it's the same data that is utilized and analyzed, and then, you know, feedback is sent back to the NCD Department of the Federal Ministry of Health and the state ministries of health. So this is the seamless manual flowchart, you know, from step 1 to step 2 to step 3 to step 4 prior to COVID. Okay, I mean, no one had envisaged that COVID would happen. But then when we were hit with the SARS-CoV-2, in Nigeria, where we had the index case of COVID in February 27th, and then in the different states at different times, in Imo, it was sometime in April 27th. But at this period, we know that many state governments and national governments had begun to implement lockdown, what you call them? So lockdown and movement restrictions, curfews. At least in Nigeria, almost every state in the Federation had curfews. You couldn't be out at a particular time. People were to stay at home. There were strict movement restrictions, except for emergency workers and security personnel, you know, who could move around. So when this happened, we were then faced with a challenge, considering the fact that this project was running and ongoing in facilities already we knew that some clients, people who were patients living with diabetes or clients living with diabetes mellitus, would also have issues or challenges with reaching, some of the healthcare facilities, because if you're coming out, you would have to show that, you were headed to a hospital and all of that. And there were really strict lockdown and curfew measures, in this state. So there was a huge concern. So we had to sit down, reconceptualize, reimagine our entire data collection process, because remember, like I had told us in the previous slide, it was manual. It was really manual. So data tools moved from one hand to the other, and just like that. And with COVID, we were expected not to even shake hands. So how then do you do this? How do we move data tools? How do we move these manual forms? So we had to sit down and think through. So in step one, we really didn't have a challenge there, because data tools were still filled manually by trained healthcare workers in the facilities when patients or clients came to them. So they would still fill their data tools, and they had their triplicate copies. M&E officers who collect these tools were already resident in the local government. So the M&E officers are not resident in one, like in the state capital, and then they go to the local government and rural areas. They are resident in these different local governments and rural areas. So it was really easy for them, to just come out of their house, stroll to the next primary healthcare center and collate these data tools. So step two wasn't really much of a struggle. But in step three, where the M&E officers HSDF was expected to either travel to pick up these forms, in conjunction with, like the state ministries, or the M&E officers were to travel to come submit this manually. There was a challenge. There was a challenge because of the curfews, the lockdowns, stay-at-home directives, and the movement restrictions. So with all of this, there was a challenge. We're faced with the problem. We didn't want, because no one knew how long the lockdown was going to last for. No one knew how long, the movement restrictions would last for. So this wasn't a case of let them keep filling up, filling the forms, and maybe after 1 year, we can, pick up all the forms, have a backlog of 1 year, and begin to do data cleaning for thousands and thousands, of forms and all of those things, and hundreds and all that. So we knew that that wasn't an option to deploy, or an intervention to deploy. So we had to sit down and reimagine what was feasible in our own context. In Nigeria, Nigeria is a country where we have a huge percentage of citizens who utilize smartphones. And we thought through it, and we said, the WhatsApp application was one that almost every single person with a smartphone had, in our country. And so based on this, we had to sit down and reimagine the processes. In-house, we sat down, had brainstorming sessions. How do we utilize WhatsApp? How do we utilize an app, as common and accessible to people for this purpose? Was this even possible? We had looked and seen, we had seen WhatsApp being used for various health interventions in countries in Africa and even in Nigeria. We had utilized it on a previous intervention, but for collecting data, we hadn't done that. So that was something that we had to, really think about. And so what did we do? After we sat down to reimagine, just conceptualize and think through this, we also discussed with the healthcare facilities and the state M&E officers, thinking through and saying, what do you think of this? That travel, to pick up forms right now is not possible. And we know that this data, we do not have these indicators on the district health information systems yet. So it's not like facilities can upload them, okay, like they upload other disease entity indicators like they do. So what then can we do? So we discussed the use of WhatsApp with the state monitoring and evaluation officers, like I had told you, who are resident in the local communities there. And then we discussed it with the health facilities. And we got over a 90-something% yes feedback, saying this is possible, let's give it a try. So what did we do? We said, okay, what would happen is facilities or state facilities will provide this completed and signed data tools to the M&E officers. So by signed, I mean data tools are usually signed by the officer in charge in the facility to make sure that, this is approved to go out, all of the, inner processes have gone through, and someone is taking ownership, for owning this data. So they were supposed to either take pictures or scan copies of this, using their phones, and then submit to a designated WhatsApp number, okay? Designated WhatsApp number that HSDF had access to, and then the state ministries of health as well. So this was what we began to do. And then after this, we will then, look through the pictures and review. You'll see in the next slide what we did with, validation at that level, because I'm sure many of us are already asking, how can you solve for the problems of quality and the challenge, of data cleaning and all of that? So we would review all of this, analyze, enter into into the database, and then analyze. But then how did we solve really for that? And I'll show us in subsequent slides. But before I show that to us, I want to show this graph. And I'll explain what this graph is. So this is essentially showing us the percentage data tools submitted between March and August 2020. And this was, really around the peak of the lockdown in our country and in the states where we work, the movement restrictions and all of that. Now, the green line, if you can see the green line there with the pretty blue dots, show percentage data tools submitted and uploaded to the DHIS2. So these are not the dark. Remember, I had told us that there is the mainstream district health information system. So that's the green line here. So this is showing us the average reporting rate of the data in one state, so in Imo State. Okay, so facilities, percentage reporting rate between March and August. And we can see that percentage reporting rate was really around 40-something% during this period of the lockdown. For uploading, for the DHIS, so the regular mainstream health information systems. But during the lockdown, using the WhatsApp as an alternative method for data collation, you can see the gray line. So we had about a 70-something to 80-something% data collation and submission rate. Now we know that there are many, there are so many confounding factors, or there are some confounding factors for this, but I wanted to show this to us because we're really excited, about utilizing the WhatsApp for this purpose. And we can see we had above, with only, I think about 160-something, we had above, 70 to 80-something%. So facility data reporting throughout the lockdown period was not stopped. It just continued. Like there wasn't really a challenge, even though we knew there was, a global challenge, but this continued. And we can see that comparing it with the district health information systems where facilities had to upload data into that, you see that there is still about a 40-something% data reporting rate. So like I had told us, remember that every facility is expected to submit one completed data tool at the end of the month. And state M&E officers would then pick this and then submit as well. But utilizing WhatsApp, this was it. So we began to look critically and say, okay, there definitely are some benefits for, utilizing alternative methods like this at times of crisis. And then post this, we began to also think, so is there, can we build a case for the use of hybrid methods? So maybe utilizing WhatsApp and then utilizing the hard copy manual. But those conversations are still ongoing. So like I had mentioned, I'm sure many of us were beginning to wonder, how did we validate? How did we maintain data quality and all of this using phone calls and all of that? Sorry, using WhatsApp. So what we did was we utilized phone calls and we utilized the WhatsApp. This is what we did. When we received the pictures, before then we had, briefed the healthcare facilities. We had talked to the state M&E officers. We told them, it's really important that your pictures the data tools are completed, they are signed, and they are clear. The pictures and the scanned copies are clear. So in step one, we would ensure that these copies were clear. Someone would look through them. And then if we had unclear pictures or unclear scanned copies, we would probably reject that and really ask for a clearer version to be sent. In step 2, while we're reviewing those data tools, we will make calls. So we would call state M&E officers and even health facility officers in charge to clarify gray areas. So did you mean this? Did you mean that? Is the denominator exactly what you were saying? I mean, from your previous submissions, you've always had, you know, maybe about 50 people coming in, and now you're having 70. Is this an error, or are you actually saying that you had more people coming to the facilities to be screened for diabetes? So we did all of these things on the phone, which usually we would have done manually. So we did them on the phone. And then step 3, we would enter the data into the project database. But throughout this entire process, you know, remember I had mentioned to us that we were utilizing WhatsApp even on the project. So throughout this entire process, we were, you know, we continued with, you know, periodic mentoring on WhatsApp on how to fill data tools, refreshing their memory, because we knew we couldn't have all of those state data review meetings, which we were supposed to have, I mean, because of COVID. So we just continued with the mentoring. We would show, you know, pictures of wrongly filled tools and properly filled tools, and have healthcare workers provide feedback. So all of this was happening throughout this entire process. So we had a cycle of, you know, reiterating and, you know, validating and discussing, just ensuring that the data that we had at the end of the day was of good quality to be entered into the database. So currently in the country, where are we with tracking the progress, you know, with expanding the diabetes indicators, like I had told us? Adapting the WHO package of essential non-communicable diseases, you remember I mentioned that earlier, and, you know, and piloting these tools have been completed. Those are the tools that facilities are utilizing. The consistent engagement with the Office of the Department of Planning, Research and Statistics, which is the office where the National Health Information Systems from facilities is domiciled. That is still ongoing. You know, we invite the director to steering committee meetings. We're having advocacy visits, you know, to this place with all the officers at that place, just at that office, just to ensure that, you know, diabetes NCDs is on the front burner. And then we're utilizing this WHO PEN tools, but most importantly, we're collating feedback from facilities utilizing these tools. You know, like I said, we're piloting them. So we're noting, you know, challenges with utilizing the tools. You know, what are the concerns? What's the feedback coming from healthcare workers? And we're collating this and sending to the NCD division of the Federal Ministry of Health. We're also looking at the inclusion of diabetes benefit packages into state health insurance schemes. Nigeria is at a point where there are numerous state health insurance schemes, you know, being implemented, being designed, being developed, and being implemented across our 36+1 states in the country. So what we're doing is, you know, just ensuring that diabetes is on the front burner as well. We are working with states to ensure that we've had meetings, you know, where we've sat down with stakeholders and state health insurance scheme officers to discuss, you know, what benefit packages exist for diabetes and NCDs in the state health insurance schemes. And I already has a national health insurance scheme, and there are benefit packages there, but so that people, you know, scheme officers to discuss this as well. Also, there's also the STEP survey. You know, I had mentioned this at the beginning, where WHO had mentioned that it was important for healthcare, for nations and countries to have their STEP survey, you know, for NCDs every 3 to 5 years. So we are at the point where we're having conversations, and HSDF is part of the National Technical Working Group for NCDs in my country, in Nigeria. And so currently we're having, you know, real conversations around, you know, designing our STEP survey and deploying this by next year. And if this happens, this would be amazing. So we will then have a globalized, you know, representation of what the NCD picture or the landscape is, you know, in Nigeria. Okay, so what are some of the challenges, you know, that we have observed, you know, from here, we've identified, and what are some of the lessons that we have learned from here? It's important to note that there can be bureaucracies, there can be bottlenecks. The journey to really expanding and mainstreaming NCDs and diabetes indicators on the DHIS2 platforms like that you plan on Monday and happens on Tuesday. And so we are still with, having those constant engagements and those meetings with the office of the DPRS, or the Federal Ministry of Health. And so that before the next revision of the DHIS2, because DHIS2 is usually revised, periodically, before the next revision, would have these expanded diabetes indicators sitting really nicely, on the DHIS2. There's also a challenge of numerous data tools. Like I had told us, many of the data processes are manual. So healthcare workers have to fill so many data tools. And with the introduction of the WHO package of essential non-communicable diseases, like I had mentioned, those were more data tools as well for healthcare workers to fill. So we had people, staff, complain, especially with the shortage of healthcare workers in certain areas in the country. In certain areas in the states where we work, this has been a challenge as well. But like I mentioned, what are we doing concerning this? We are collaborating really nicely with the NCD division of the Federal Ministry of Health. And the idea is, while we're piloting these tools, we're noting all of the feedback so that at the end of the project, we can have a seamless integration, of the DAC tools into the existing tools, so that healthcare workers don't have, just extra tools for almost every single disease entity that exists, so that there's a seamless integration into what exactly we have, and we don't have too many parallel data systems. There's also the concern of staff attrition. This was a huge one. Sometimes staff have been trained, and then there's a high rate of staff attrition or staff turnover. People leave they just exit one facility to another for some of the private primary healthcare facilities that we work with. And you really cannot stop people from moving around. And so sometimes we've had to have like frequent training sessions. But for sustainability, how can we then sustain this? Because we cannot always be there. Experts will not always go to train healthcare facilities. We had like a training of trainers, where there's a pool of mentors who were drawn from the Federal Ministry of Health, the state ministries of health, her departments and agencies, and experts, so endocrinologists as well. And so this pool of mentors are resident in the state. They're part of the civil service. So even when the project ends, they are there and they can always retrain. They are the ones who go around for the mentoring visits and retrain facilities. They have conduct on-site training. So this is one way of ensuring that irrespective of the staff attrition challenges that we may be faced with on the DAC project, we can have a continuity or sustainability mechanisms, just really integrated into the program. And of course, with the use of WhatsApp, so just thinking innovatively, at some point, state M&E officers would either request funds for purchasing data bundles, and so we're faced with that challenge of how sustainable is this. Currently, some facilities have reverted, to the manual collection process. A few M&E officers still upload data, but we're really thinking about what is best. Do we sustain this hybrid method with the whole conversations of a second wave of COVID coming in? If there's a second wave and then we have lockdowns again, what happens? So these conversations are ongoing. We're also discussing, with the state at our policy meetings, just really to identify what the best and feasible options, are for this as well. So I'm going to show us a few pictures of some of the data tools, the WHO package of essential non-communicable disease tools that are currently used at the facility. So this is one of them. This is another. So this previous one, is the monthly summary form. Like I told us, there are several tools, about 4 to 5 of them. So there's the monthly summary form. There's the client intake form. There's the client referral form, okay? There's the general screening register. There's the treatment register on my right as well. Okay, so in conclusion, really, achieving data demand, visibility, and maintaining quality for data is a general challenge in countries. It's not peculiar to Nigeria alone. But what are some of the recommendations, from some of the lessons that we have learned thus far? Some of the recommendations that we can make. One of them, there are three big ones that really stand out for us. One of them is mainstreaming NCD indicators, and I had mentioned this in the course of my presentation. It's important that with the burden of disease, for NCDs in Nigeria and in Africa, like I had told us, for us in this country, and I think this is also same for LMICs, NCD indicators must be mainstream. They must be included in the national and subnational. So for every health data system that you must have NCDs there, okay? Because this is more like a global pandemic, and this is a priority globally for the different continents, and then for even our country. So this is one thing that you must do. So if it's not yet there in your country, it's something that you want to do. You want to identify if in your state strategic health development plans, if in your health information systems, and all of those, high-level policy documents and databases, that NCD sits really nicely, smack in the middle there. You also want to take note of innovation in times of crisis. The world in which we live in, or the world in which we were born in, no longer exists, really. So how can you reimagine current processes, for times like we had with the COVID pandemic? How can you reimagine your processes and develop effective data management systems, that have a potential for sustainability, there's a potential for, a multiplication, so a multiplier effect. How can you do this, really? And then thirdly, there must be a constant or a consistent and effective stakeholder engagement if you must achieve data visibility in your country. Okay, so this is something that must be done. You must identify which offices, which ministries, which agencies are responsible for maintaining or improving data visibility, data demand, data quality, and consistently engage, with those agencies and those departments and ministries. So in conclusion, really, these are three big things that, we have learned, and these are huge lessons for us. And these are also recommendations for LMICs like Nigeria, or countries with huge populations like Nigeria, or countries with similar contexts and challenges like Nigeria has, who may want to achieve these same outcomes as well, for data. These are three things that you really want to consider: mainstreaming NCD indicators. You want to really think through innovating and disrupting the status quo if need be, or where applicable, and then you want to engage, solidly with relevant policymakers, okay, to achieve that. So on that note, I would say thank you for listening, and over to you, Kaitron. I'm happy to take questions and comments.